Hello and happy Teach Me Tuesday. My name is Lisa. I'm an experienced NICU nurse and a NICU nurse educator here to bring you a NICU topic broken down into a little bit so that you can learn a little and get on with your day. April is HIE Awareness Month, and so in sort of a theme that maybe you didn't know you were being a part of, we have been leading up to this, the fourth Tuesday of April, to talk about HIE and therapeutic hypothermia. And the reason that we talked so much about NRP for 2 weeks, last week we talked about congenital diaphragmatic hernia and kind of the variations that you do at resuscitation, and now we're kind of leading all together to HIE because actually all three of those things, what happens during resuscitation and kids with CDH and their hypoplastic lungs, pulmonary hypoplasia, all of that is going to contribute to HIE. So it was all kind of a theme that you didn't know you were a part of, but here we are. Let's talk about what HIE is. So the H in HIE is hypoxic. Hypoxia means inadequate oxygen. So for whatever reason, there is not enough oxygen getting delivered to the baby. Ischemia means when there's decreased blood flow. So not only do we not have enough blood flow, but the blood flow that we do have is low in oxygen. And then encephalopathy is this idea of brain injury. So that's what we're going to talk about today in the United States. So we're going to talk about kind of our modern, I hate the word first world, developed countries, right? 2.4 out of every 1,000 births are diagnosed with HIE. If you work in a level 3B or a level 4 NICU, you are probably treating these babies. If you work in a level 2, a level 3A, you may be stabilizing and shipping them. This topic is for all of us because it is so important to know what we're looking for and how we can help them. It's also crazy. We've talked so much together about how neonatology is young and continually evolving. This idea of cooling for babies has only been around for 20, 25 years. So it's still pretty young, which is crazy to think about. So we go back to that idea of what is HIE? It's reduced oxygen delivery, reduced blood flow that leads to brain dysfunction or injury. It comes from a perinatal or intrapartum event or something that happens immediately after birth, and it can be mild to severe, and anyone from mild to severe can have big long-term outcomes. Throughout our time together today, I'm going to give you a couple stories that just kind of tie this all together that I think will kind of help you. But I do think that this graphic helps, right? It's a shortage of oxygen, a shortage of blood flow that causes some amount of brain damage. So what contributes to this? What are risk factors? First, let's talk about the placenta. To know me is to know my love of the placenta. I like to talk about how the placenta is the greatest temporary organ to ever exist. And then people remind me that it's the only temporary organ to ever exist, but I digress. The placenta's job is to do many things for the baby that once the baby's out, the baby has to do themselves. But the placenta serves as the lungs. It exchanges the gases. It serves as the liver to get rid of waste. It serves as the nutrition source. It serves as a place to get all of your growth. So if you think about if something happens to the placenta, it can affect the baby. So when we're talking about HIE, we can think about things like placental abruption, okay? With abruption, the placenta is separated from the uterus and there's profound bleeding. So the placenta is not working, so we're going to have a buildup of all of those toxins and byproducts such as CO2. We're not going to get oxygen to the baby, and we're going to be volume depleted, right? Placental insufficiency can go along with IUGR preeclampsia. If the placenta doesn't work well, you can imagine that there's going to be a buildup of these same things. Previa, this is what is in the picture here. Previa is when the placenta, instead of adhering up in a wall away from the cervix, adheres close to or on top of the cervix. And as we all know, when a baby is descending so that they can be born, the head goes down towards the cervix. So now you can imagine that this head is pushing on the cervix. It makes it so that the placenta is in the way, right? So now the placenta is being kind of squished, so it's not going to work as well. If the cervix starts dilating, right, we're in trouble for that placenta, and there's a risk for bleeding. So all that comes together. The placenta is also meant to be a temporary organ, meant to live about 40 weeks. So when we go past that 40 weeks gestation, it also starts failing. So again, these are all contributors to HIE. It means that they are risk factors that, if present, may cause decreased oxygen to the baby, decreased blood flow to the baby, HIE, which causes brain problems. Then we have our umbilical cord risk. So nuchal cord is when the cord is wrapped around the neck. It can mean nothing. If you've ever been at a delivery during your resuscitation, right, in NRP, you might hear somebody say nuchal times 2. That means the cord was wrapped fully around the baby's neck twice. True knots in the cord. So what I want you to think about the cord is it is the connection between the placenta and the baby. So we just talked about how the placenta is the single most important temporary organ to ever exist, all the things it's doing. If it can't get those to the baby, it's not getting the oxygen to the baby. So just like any knot, anything that's, compressing that cord, the worse it is, the worse it's going to be for the baby. So cord prolapse, right? That emergency when we see, they say we got to get a hand in, that's so that we can get the head off of the cord. So we're not, again, cutting off oxygen. So if you've seen that where a labor and delivery nurse is on the gurney with the mom rushing off to surgery, that is a medical emergency. Cord rupture, cord accidents, all of that. Again, this is the tube, essentially. If you have a kink in your tube, we're not going to be able to get that adequate blood flow to and from the baby. Our uterus, our biggest risk factors, obviously uterine rupture, more likely to happen in the setting of multiple cesarean sections because your uterus is a muscle, right? So if you've had a cut through a muscle that's been sewn back together and then that muscle stretches again with the next pregnancy, the scar tissue is stretching. You can see, especially in the setting where labor begins and the uterus has to stretch and contract for this to happen, you can imagine how that would be a risk factor. So again, if the baby is a long second stage of labor, mom's in labor for a long period of time, that can increase your fetal distress. Anytime that there is extra pressure on the baby from medications that we have to give the mom during delivery, and then obviously from hemorrhage from that placenta previa that we talked about, or accreta. So accreta is when the placenta actually embeds more through the walls of the uterus. So at first, it's just supposed to be in the outer layer, then it goes into the muscle. The placenta can actually go in and through and attach to other organs in the mom's body. I've seen that before. I've seen a mom come out of a C-section with a catheter because it hurt her bladder and an ostomy bag because it attached to her intestines. So pretty intense. Other contributing factors. This is a pretty comprehensive list. I'm not going to say it's everything, but trauma, so car accidents, something happens to the mom, a fall, etc. Shoulder dystocia, where the baby kind of gets stuck. I would say that's one of the biggest ones we see. Meconium aspiration syndrome, severe fetal bradycardia, instrumented deliveries. Remember, an instrumented delivery means you're using forceps or vacuum to get the baby out. We don't do that for fun. We do an instrumented delivery typically because labor is taking too long or the baby's in distress, both of which are risk factors for decreased blood flow and decreased oxygen to the baby. So it's not necessarily that you have to use that. It's like the forceps. It's why you're using the forceps. Postdates we talked about with the placenta. HELP syndrome, obviously the mom is as healthy during this pregnancy. We also have a clotting issue often with the platelets, those LGA babies getting stuck. Amniotic embolism, I put this on this list because this has been in the news for those of us that kind of follow social media with the nurse influencer who recently passed away from an amniotic embolism. If this happens right during labor, the mom goes into cardiac arrest, the baby isn't going to be seeing any blood flow. I have seen this. The most recent amniotic embolism I saw, the mom did not make it. They did a crash C-section in the labor and delivery room. They didn't even get her to an OR. The prolonged period of time that the mom got chest compression, so the baby was at risk for HIE. So that's why I wanted to include that on there. And then these home births, either purposeful home births without proper monitoring or accidental home births where the baby comes before you're ready. We've had side of the road deliveries where the baby isn't doing well and they come out. We had one situation once where the mom had a placental abruption at home, and so the baby was prolonged period of time where the baby did not have blood or oxygen flow. So what does this mean? So for some reason, from all those reasons we just talked about, there's a decreased oxygen and blood flow to the brain. So the neurons are deprived of things they need, oxygen and glucose. This causes them to start going into anaerobic metabolism, which increases your lactic acid. Your ATP production drops, causes cell swelling. These neurotransmitters like glutamate are there released excessively. There's more calcium influx coming into the cells. So all that causes cell death and kills these neurons. So this little area in the brain that is having this deprivation of the oxygen and the glucose and the blood flow, it starts to die. And that is what's happening when you look at an MRI of a baby with HIE. If you're watching the EEG or an AEG to see if there's seizure activity, this is what's happening. Is this whatever area of the brain it is? I saw a picture once where it's kind of like, I actually think it was in a stable class, where the brain is there and then you see this like little circle of area where it's a different color. And that area, those cells have died. And this can happen over hours to days. And so what we're trying to do is to stop that. So how do we stop the spread of this disease, where the spread of the injury, where the spread of this dead cells is happening? How do we stop that? Well, we do it with cooling. So who do we cool? Cooling is for babies born greater than 36 weeks. There are units that go down to 35 weeks, and there are studies happening going down to 34 weeks. So pay attention to those things going on. Currently, we're looking for birth weight greater than 1,800 grams. We need to get them within 6 hours, and that's because of what we just talked about on the previous slide, that we are trying to stop the spread of the injury in the most crucial time, which is reperfusion injury, which we'll talk about. We're looking at that cord gas. So again, has the lactic acid built up enough? Has the baby retained so much CO2 that their pH is so bad or their base deficit is so high? So we're looking at cord gas, which less than 7.0 or base deficit greater than -12. Do they have signs of moderate encephalopathy based on their neurologic exam? SARNART is the gold standard for what to use. It has a mild, moderate, and severe. If you're following me on social media, we're going to be talking about this week, so make sure you go and check that out. Altered consciousness, weak or absent reflexes, seizures. That's what we're looking for in that neurologic exam. So if you're at a delivery of a 37-weeker who weighs 3 kilos, who comes out, requires excessive resuscitation, their APGAR score at 5 minutes is less than 5. That means for 5 minutes, we have been doing everything we talked about in NRP. So let's flash back to what we talked about for the first 2 weeks of April. We talked about getting that PPV going, getting within 30 seconds. Mr. SOPA, if you do all the steps of Mr. SOPA, all the initial warm, dry, and stim, the A of Mr. SOPA, you're pretty much at 2.5 minutes. So by 5 minutes, you're intubated. So if your APGAR is still less than 5 at that 5-minute mark, we know we are in trouble. And that's why we focus on that APGAR and not the first minute APGAR, right? So that's the why behind that APGAR. The cord gas we talked about, right? It also tells us the length of time that the baby's been in distress. So if your cord gas is below -7, we know the baby's been in distress for a period of time. So why do we say cord gas or initial gas? The reason that we say that is we don't always get a cord gas, especially in these settings of a uterine rupture, a placental abruption, a cord accident, all these things where the blood has come out, we may not be able to get a cord gas. But we need to get that initial gas, especially within 1 hour, because we, as NICU providers, are very good at ventilating babies. And so we may not see the full extent of what happened because of our keen resuscitation skills. And in those situations, your pH may be good, but your base deficit is still going to be bad. We've talked about blood gases. We're going to do that again this summer, but I want you to think about how long it takes to correct a base deficit of greater than -12. It takes a long time. So our 1 hour of ventilation efforts have not fixed that, and that's why you use your cord gas or within 1 hour your initial gas. So those are the whys behind all of those. So what is therapeutic hypothermia? The goal is to get the baby to a core temperature of 33.5, right? We nurses, medical providers have been cooling adults after MIs, strokes, accidents. I don't actually know all the reasons because I'm not an adult nurse. I've never worked in an adult ICU, but I know that they go on cooling blankets because I've helped them with it. But we in NICU have only been doing total body cooling for 15 years. We started with head cooling, now we're at total body cooling as the gold standard. And again, I'm talking about in developed countries. In Developing countries, they don't always have these resources. So we want to get them there within 6 hours, right? We talked about why we want to get to that place where we are not pausing the spread of the injury. We do it for 72 hours. We slowly rewarm. There is danger, and this is good to know for premature babies, for everyone. There is danger in quickly rewarming anyone because it causes this flushing. So in premature babies, if you have a cold baby who you're trying to rewarm, it should take you an hour or so. Always remember that. You should not be rewarming a cold baby fast. Same thing with these babies. It's probably going to take 6 hours or more to rewarm them. Again, slow the metabolism and limit the brain damage. So what's the pathophysiology of cooling? Why is it working? So after that initial injury, right? We didn't have oxygen. We didn't have blood flow. Now we do because we've resuscitated you. We're giving you oxygen. Maybe we're giving you fluids for your blood flow. We're giving you blood, whatever it might be. Some of these damaged cells may recover, right, during this latent phase. But without intervention, a secondary energy failure occurs. So during this time, there's lots of big words here: mitochondrial failure, free radical formation, inflammation, apoptosis. All of these things are going to start happening unless we say to the brain, hey, you know what? We actually don't need you to work really hard right now. We don't want you to be using any energy. We don't want you to go into a secondary energy failure. And to do that, we're going to cool the baby. That's why it started with head cooling, right? We thought we just needed to cool the brain, but we learned we need to cool the whole body. So therapeutic hypothermia is interrupting this process by limiting cell metabolism and energy demand. It's saying, whoa, 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 everybody quiet down. We're going to quiet down so that this area of concern in the brain doesn't spread. We're going to limit the free radical formation, we're going to suppress inflammation, and we're going to delay or prevent apoptosis. What I want you to say today and take away, if it only take away one thing from our whole time together, is cooling does not repair the injury that already happened. Cooling prevents the spread of injury. So it preserves brain tissue by stabilizing the injured cells and prevents further spread of damage to the surrounding areas. I'm going to say it one more time for everyone. Cooling preserves brain tissue by stabilizing the injured cells so they don't continue to die and prevent further spread of damage to the surrounding areas. Okay? So that's the why. That's why we cool. Cooling does not reverse the injury that has already occurred. It prevents the injury from spreading to other areas of the brain. The injured cells may stabilize and begin to recover. The cells that have died are not going to recover, but if they're injured, they may recover. The overall goal of cooling is to reduce the risk of long-term developmental delays, cerebral palsy, and other neurological impairments. So again, one more time, we can't, if you think about the picture I've been painting for you of this brain with a circle of an injury that's a different color, we're never going to turn that color back to normal, but we can prevent that color from spreading. And the baby's brain is going to continue to grow, right? They're going to grow all these new neurons if we're able to save enough of their brain. I took care of a baby once who had the resuscitation, everything we talked about in NRP, every single medication, blood, everything. We got the baby's heart rate back at 25 minutes. That's how long the baby was down, not to discount what happened in utero as well. The baby was on every medication I've ever seen. It was one of those times where we had to take the art line out, the UAC, put in a peripheral art line, very unusual. There was no activity happening on that brain monitor. And that baby, after 72 hours, we rewarmed. He did well, and he went home breastfeeding. If you've been following me on social media, you saw me put about those life-changing moments in my nursing career. That was it. That was him. And I'm getting chills just talking about it because we were able to preserve his brain during this period of time and allow it to recover. And then all those new cells grew around that injured area. That injured area is always going to be there. He's going to have impairments. I know that. I'm not naive. I know he's going to have impairments. But home with no oxygen, breastfeeding, he's going to do pretty great. And that's really awesome. So that 72 hours is how long they cool. And then 6 to 12 hours later, they do that gradual rewarming. During this time, you should be having some sort of seizure monitoring, whether that's EEG, AEG, whatever your unit uses. Especially in the beginning, you're going to be checking tons of blood gases. You should be seeing a slow correction in your lactic acid and in your base deficit and your pH, obviously. Again, major swings in any lab value is never great. So we're going to be doing a gradual change in that, Coagulation studies, there is a bleeding risk here. That baby I was just talking about had a major bleeding DIC situation where we were doing tons of blood products. And then obviously watching our perfusion and cardiovascular status. I am going to throw this in here while we're on this slide. I was asked on social media once, like how I take pictures in the rooms and of the babies. Everything that I'm posting is either from a simulation center or I buy stock photos. So this is a stock photo. This is not a baby I ever took care of. I've never even seen this cooling blanket. I have no idea what we're looking at. So just to throw that out there in case you're wondering. All this to say, we also have to support our parents during this process, right? Cooling therapy is a standard treatment to protect the brain. It's not going to eliminate the injury, but it's going to improve the outcomes. Some infants are going to do great. Some infants, right, they come down, they get on the cooling blanket, they're intubated, we put lines in, and 6 hours later, we're already extubated. We still keep them on the blanket for that full 72 hours so that we can make sure that we are going to preserve as much of the brain as we can. And they may be on room air, and this is where that whole idea of if the parent asks you, why can't we feed them, comes into play. There is mixed evidence in the research about if we should be feeding babies during cooling. And the reason is we're cooling the whole baby. So if we are slowing down this idea of energy expenditure, the gut's probably going to slow down. So if we're putting food in the gut, do we increase their risk for neck? Are they going to be able to digest? So it's a pro and con there. I have definitely seen kind of what we call comfort feeds, where we give the baby maybe 10 mLs if they're on room air and kind of upset instead of having to give them sedation. So something to think about. Sedation during this, I've had parents ask me, is this uncomfortable? The baby's shivering. And that does happen. And there are some babies that need some sedation during this. It's very cold, right? If you've taken care of a baby on the cooling blanket and you touch them, they do feel very cold. Same thing about, will they be able to hold their baby? There are cooling blankets in which the parents can hold them. It's not going to be a skin-to-skin style, but there are some cooling blankets out there where they can at least have them in their lap, feel the weight of them. But what are some other ways that they could bond? Diaper changes, temperatures, oral care, offering the pacifier, holding their hand, etc. This idea of HIE, again, I've talked about this before. I've talked about what the hardest part of adjusting to being a NICU nurse was for me, and that's the term baby thing. I just hadn't really realized how many term babies were going to be so sick, and it's so unexpected. When you have a preterm baby, you think to yourself, okay, yeah, like this stuff has to happen, but with term babies, you weren't always expecting that. HIE is one of them, and parents often think that this is their fault, and so it's just a reassuring to them. And then what's our follow-up going to be like? What are our neurodevelopmental programs, etc. So I thought this was going to be 25 minutes, and we're going to get under. I'm so proud of me. So again, HIE requires swift action, close monitoring, cooling within the first 6 hours. If you are a nurse that works at a level 2 unit that ships your babies out with something like this is when you're going to start passive cooling. Make sure you don't get the baby too cold, and we don't get too cold too fast, so be paying attention to that. Maybe your unit's going to place the lines for the transport team, or the transport team's going to get there and get lines in. We're trying to get them to that core temperature of 33.5 within 6 hours so that we can stop the spread of the injury and improve the long-term developmental potential. The one other big thing I want to talk about is this idea of if the infant is in a level 2 nursery or in a mom baby unit or in the NICU and maybe had somewhat of a moderate resuscitation, but not this full resuscitation, it's our job as NICU nurses and newborn nursery nurses to be looking for those subtle signs. So if we start noticing seizures, if we start noticing a change in our neurological assessment, that we escalate those to the provider so that we could catch them in this window. So recognizing that, paying attention to your blood gases. If you get a cord gas back and the baby's in the newborn nursery, making sure you're escalating that. And then obviously supporting our families through that. Thank you for joining me. I will see you next week. We have a 5th bonus Tuesday in April. So I will see you for our 5th and final Teach Me Tuesday of April. But I hope you have a wonderful day. And please let me know if you have any questions.